Evropiane Pediatrike, me përmbledhje nga Kongresi 56 i Shoqatës Evroipiane të Nefrologjisë Pediatrike, që është mbajt në javën e fundit të Shtatorit në Valencë. Me 915 pjsëmarrës, me 66 sesione paralele, me 34 folës të ftuar ekspert të fushës, me shumë postere e komunikime orale. Është vendi ku në mënyrë perfekte kombinohet përvoja profesionale me marrëdhëniet njerëzore, ku prezentohen rrisit e fundit në nefrologjinë pediatrike. Është vendi ku frymëzohesh dhe në të njëjtën kohë ndjehesh si një familje të madhe. Përmbledhje të rrisive nga ky kongres do të paraqiten nga pediatër nefrolog me ekspertizë të lartë në fushën e tyre, me ekspertizë ashtu në krijimin e udhërrëfyesve të nefrologjisë pediatrike. Jam e nderuar dhe shpreh mirënjohjen time të sinqert për kontributin e tyre të jashtëzakonshëm në platformën tonë edukative. Të ftuar janë profesor Konstantin Kamperis, profesor universitar në Universitetin e Danimarkës, kryetar i Shoqatës Internacionale për Inkontinencë të Fëmijëve. Profesoresh Julia Höfele, konsultante nefrogjenetikiste, profesor në Universitetin në Munich. Profesor Detlev Bockenhouer, profesor në University College of London, punon në Universitetin Leuven në Belgjik dhe është honorary consultant në Great Ormond Street Hospital në Londër. Profesor Olivia Bolivier, profesor universitar në Universitetin e Parisit në Francë, ku edhe punon në Spitalin e Fëmijëve.
Professor Kamperis, welcome to Pediatric Horizonte, our educational platform for pediatricians.
Thank you for the invitation.
I enjoyed the last session of bladder dysfunction. It's the part of the nephrology that I work a lot, and I have patients, and I love that part of the nephrology. And unfortunately happened to come patients after years of treatment of urinary tract infections, not resolving, and desperate parents trying to find solutions. And what would be your message to pediatricians? When should they think about bladder dysfunction?
That's a good question. I think first of all, all pediatricians have to be aware that the bladder is extremely important. They are seeing a lot of patients with urinary tract infections, incontinence, and so on. So I think the majority of patients that have a bladder dysfunction would present at some point either with infections or with incontinence episodes. And many of these patients, the easy thing to do would be just to treat the infections as you do with adults and then send them home. But I think it's very important to identify the issues with the bladder function, because these children are going to come back, and many of them, they may have like reflux or reflux nephropathy, and at a later point they may lose kidney function because we don't care too much about the bladders. So I think this is the main category of patients that they have to be in a way alerting themselves about and examine their bladder function. You know, checking the bladder in a way, it doesn't have to be too complicated. Just by using a frequency volume chart over the weekend, which every child would do and it costs nothing, you can get a lot of information how these children's bladders are behaving. Then non-invasive Euroflow, it's also very easy. There are machines that they are cheap and they are easy to use also at home. So that gives you a lot of information to identify the ones at risk for developing issues with the kidneys and staying bladder dysfunction.
Yeah, and usually, as you mentioned, incontinence, usually the parents when you ask them, they say they have infections, they have this bacteria, that bacteria is not going away. And when you ask them, oh yes, do you have that wettens? Yes, they are wet, but because of the infections.
Yeah.
Usually they argue that might be because of infections, and happens not to be that. That. So, I think we should think when, for example, you treat an infection and what is coming back again, or for example, is going like improvement about a week, and wetting coming up again. Don't think about infection, might be, but it's more.
Yeah, I would say it in two different ways. First of all, you can see the infection as a symptom of a bladder dysfunction.
Yes.
So you just have to identify the reasons for that. And I would say that for all pediatricians, and again, because it's relatively easy to do the workup, I would say that every single child that presents with a urinary tract infection, and I would also say regardless whether it's a lower or an upper urinary tract infection, they do have bladder dysfunction unless the opposite is proven. So we have to look into their bladders. And in some cases, it could be just by questioning the family and figure out that, okay, that's okay. Sometimes we need the uroflows, we need the frequency volume tests, but they are still quite cheap examinations.
Yes.
Then we can spare the child perhaps for many infections if we treat their main issues. And the last thing I want to mention is not just about the bladder. Many of the children, they also have bowel dysfunction. It's not very uncommon in children with constipation to present with urinary tract infections. And if we don't treat that, we can't get rid of the urinary tract infections.
Yes, sometimes by treating bowels, you just got improvement on bladder. Yes.
This is important, not just for we as pediatric nephrologists. We know these issues, we see the children, we see what happens to them when they lose kidney function. But I think the main work has to be done on the primary level, GPs or pediatricians.
At least find out and then further refer if they don't have experience in that bladder, but think of bladder dysfunction, And something else that was mentioned in the session of the bladder was lower tract, urinary tract anomalies like urethral valve and hypospadia, epispadia. Usually these are involved, like incorporated or comorbidity with the bladder also. So they should be evaluated more, I think.
I think many of the children end up being seen by pediatric urologists. They, of course, they do
resolve the operation.
Exactly, but then, I mean, many of the children have a continuous issue with their bladder, even though you remove the valves and everything looks fine. They're going to face issues with their bladder function, so they need care by pediatricians as well that can have a holistic picture of the child as a patient. So that's important, the collaboration between the two. In our clinics, we kind of see patients together with the pediatric.
Like joint clinic.
Exactly. So, and this gives, many times it's okay, it doesn't need to take too long time to see these patients, and perhaps we don't contribute too much, but sometimes you can see that we do things differently and we think differently. And we are complementary to each other. So that would be the best case scenario to have this.
Teamwork.
Exactly.
Like teamwork. It is like the solution that will end up in each country, but sooner or later.
It's always a discussion about resources. Do you have the time? Just by, I mean, it doesn't need necessarily to be just clinics, joint clinics, just that each discipline has good access to the other one. That would also help. Just talk to each other, have conferences, for example, MTT conferences, and discuss patients, and be aware that this is an issue with the children that have to be addressed.
Professor Kamperis, thank you very much for being our guest. Julia, welcome to Pediatric Horizons of Kosovo, educational platform for pediatricians. We just had the working group of Kakut and kidney bladder dysfunction. And there are a lot of speaks and about the early diagnosing and follow-up and the prognosis of the kidney damage after the operating or because of this kidney dysfunction and dysplasia and anomalies of the kidneys. What should, for example, an obstetrician or a pediatrician, neonatologist, which they first met the child, what should they be aware of and do next steps?
So thanks for inviting me to this session. It's an honor for me to be here. I think it's very important that all pediatricians or neonatologists and so on contact a pediatric nephrologist or even a nephrologist when they be aware of a kidney disease in their patient, if it's a pediatric patient or an adult patient. Because I think a nephrologist or a pediatric nephrologist can handle the problem very well, and he's more experienced in the problems, which can have the patient at the moment, but also in the progress of the disease, and it can avoid probably CKD, so chronic kidney failure, in the future.
You are a geneticist, and tell me, for example, what should they think if they have a patient with the kidney problems about all the family? Should they go further for investigating other children or siblings?
And so on, yeah, of course. I always recommend to contact a human geneticist pretty soon when they have the patient in front of them. Then they have the first contact with this patient with this kidney disorder. Because the geneticist can say, could it be a hereditary cause for the development of this disease or not? And if we have a hereditary cause, we can find it out, we as human geneticists, and can then give a recommendation concerning therapy and recurrence risk in further pregnancies, and also the progress of the disease. Can we make an influence on the development of this disease if we use this therapy or another one?
Okay, and should it be, for example, severe anomaly or whatever anomaly of the kidney and the bladder?
I will do it all the time, because if you have the contact to the human geneticist, it's not only that you say, okay, there has to be a genetic analysis. Of course, the human geneticists decide if there is an indication for molecular diagnosis or diagnostics or not.
Yes, even so, as we heard in the speakers here, they mentioned that even the least severe anomalies of the kidney have, let's say they have a CKD, like about 12%. They mentioned. You find in your surveys kind of a loss of the kidney function.
It depends on the disease. I think if we have, for example, microscopic hematuria, we don't see CKD in the pediatric population, but we will see it in the adult population. Okay, they're getting older. So, but we can avoid it, or we can at least prolong this disease progress
further.
For decades.
We can take preventive steps in order to.
Yeah, you can start with the prevention in the pediatric population and can try to avoid the CKD for the adults.
Yeah,
and this should be, I think, the most important thing you can do as a pediatrician.
Yes, and was mentioned also now new treatment strategies for. Or future treatment strategies which are based in genetics, like with organoids, and what our hope for this?
The hope would be that we have for all of the kidney diseases some preventive therapies, I think, in the future. Now we have the first steps, like we have it in ADPKD with the tolvaptan, or we have it for the ADTKD with the SGLT2 receptor antagonist. But hopefully we'll have it for further, also pediatric kidney disease.
Okay. Julia, thank you very much for these thoughts and for the working group CACUT organization. Thank you.
Thank you so much.
Welcome to Horizonte Pediatrike. It's a educational platform for pediatricians. During this ESPN, there are so many sessions on tubular disorders. And what would be your perspective for pediatricians, like a summary or insights of the discussions that are done, and a lot of them for the tubular disorders?
So I'm, of course, pleased that there is so much about tubular disorders. Usually tubular disorders are the poor orphan in the family, and everybody talks about glomerulus and chronic kidney disease and dialysis and transplant. So I'm always pleased that there's a bit more about tubular disorders. But there are usually rare disorders. And just to understand them, the tubulus is what provides homeostasis, maintains volume, blood pressure, makes sure the electrolytes are in the right concentration. And if the tubule is broken and there's a defect in there, then that can have really profound consequences. If you're losing phosphate, for instance, you can have severe bone manifestations. If you're losing potassium, you can have heart rhythm abnormalities. If you're losing sodium, you can become severely hypovolemic. If you're losing water, you can become dehydrated. So there can be really severe consequences. And even though they are rare disorders, I think it's important to always think about them in a child that has an unusual electrolyte pattern, acid-base abnormalities, even bone abnormalities.
Short stature, polyuria.
There's many reasons to have short stature. Many.
Yes,
and
so
tubulopathies maybe this little bit, but just to think about it and consider it and look at the electrolytes. For short stature, the key thing to look at, I think, would be acid-base status. Is the bicarbonate concentration normal? Is the pH normal? So it's just one of those things that you should have in the back of your mind as part of the differential diagnosis.
There are also novel treatments that are mentioned, and also like genetics, which is yours.
Yes.
Expertise, very high expertise, and you always have a doubt about these genetics, like certainty. Is it uncertain of certain gene that is doing this or that in tubulus?
So if we do genetics first and then the new treatments, which of course is much more exciting, but it is estimated that a quarter of the published genetic information is erroneous. So that a quarter of the variants and even genes that have been published as disease-causing are erroneous. And we've seen, I think, potential examples of that here as well. So there yesterday was a report about a retrospective analysis of patients with mutations in the phosphate transporters, the sodium phosphate transporters in the kidney, NAPI2A and 2C. And this was a group of patients who all had symptoms, nephrocalcinosis, hypercalcemia, and because of that, the physician ordered a genetic test that included these disorders. And for the survey, only those who actually then were found to have a variant were included.
Yeah.
But by definition, everybody had a symptom. So they say if you're a carrier for a loss of function variant in one of those disorders, 100% of you will have symptoms. But that's, I think, not true. Because when we look in databases where you don't have the selection bias, where you only look at patients with symptoms, but look at the whole population, then, and you look, for instance, at nephrocalcinosis, then the frequency of these variants in patients with nephrocalcinosis is not significantly different from that in the control population. So there's an extreme bias, I think, because you're only looking at your candidate in those who already have symptoms. So there are some problems still, I think, and it really highlights how important it is that we very carefully go through all this published genetic information, which is what's happening, for instance, in the ClinGen consortium, in order to make sure we have the right data, because otherwise you may give patients the wrong information. You make the wrong diagnosis. You may advise them against donating for your family member wrongly. You may give them the wrong prognosis. You may terminate a pregnancy because of this erroneous information. So this is really, really important information, and we need to be absolutely sure that it's correct.
And confirmed by the experts which are in the field very...
Yeah, but again, there are these global consortia like the Clinium who go through all this very, very careful.
Yeah.
I'm part of that for the tubular disorders. It's very strenuous because it's together with America and Australia and all these countries. For me in Belgium, the meeting usually starts at 11 p.m. at night and goes on until midnight. So it is not the easiest thing to do. Yeah. But I think it's really, really important because we do not want to give the wrong diagnosis to our patients and give them the wrong information about their disease.
Yes. Yeah. And also in controversy session, it was interesting, like giving drugs, but not giving too much.
Yeah.
Also the salt, take it, but not too much. So it is really tricky to get the right diagnosis, but also the right treatment and right titration of doses. And
well, I think this is, again, we're supposedly living in the area of precision medicine, but today was the session on the use of non-steroidal drugs in tubulopathies.
Yes, which is common even in other inflammatory diseases, not just in tubular. And people maybe overuse it.
Well,
otherwise
they may overuse it, but the side against the use of these drugs used all data from kidney disease in general.
Yeah.
But tubulopathies are different.
Yeah.
So, for instance, if you have salt-wasting tubulopathy, it's very good for you to eat lots of salt. But if you then say, but salt is bad for you, that's bad for the general population. But if you're losing it, it's actually good to take salt. So I think you always have to make sure that you interpret these data in light of the specific diagnosis of the patient.
Yes. Professor Detlef, thank you very much for your insight of ESPN.
Professor Olivia, welcome to Horizonte Pediatrike, our educational platform. During this ESPN, we had a chance to listen a lot of chance of nephrotic syndrome talks, and this is quite a problem actually for children. It's a disease that is quite often, and pediatricians have to take care of these children despite the nephrotics. So what would be your recommendations for pediatricians?
Yes, so during these ESPN meetings, we had a lot of new data to explain the disease. So we know that a small proportion of children have genetic disease, and in this case, they will develop chronic kidney failure and be transplanted. But the vast majority do not have a genetic disease, but have an immune disease. We didn't really know until now what was the cause of this immune disease leading to nephrotic syndrome. Now we have identified that there are both B-cell disturbances in the immune system and also disturbances of the B and T cells interaction. We know now that there is a production of autoantibodies that target the kidney cells in the nephrotic syndrome flares. And mainly, the main autoantibodies are the nephrin autoantibodies. So they have been identified by an American team 2 years ago. And during this meeting, Tobias Huber greatly showed their data that were published in the New England Journal of Medicine this year, that approximately 52% of all children with nephrotic syndrome have these autoantibodies in their plasma, and even 80% during flares, and even 90% when they are tested before introduction of immunosuppressive therapy. So what we don't know now is whether these autoantibodies are the cause of the disease or a biomarker, but that's a very important news. So then to treat the patient now, we have to treat them like an autoimmune disease, even if it's not completely an autoimmune disease like lupus or etc. So the first treatment to give to a child with nephrotic syndrome is steroids. Steroids is the only treatment that will quickly help achieving complete remission with no proteinuria and normalization of albuminemia. So the steroids, we have now greatly reduced the dose and the duration of treatment that we give, because there has been some published randomized controlled trial showing that 2 months are similar to 4 months or more of treatment, and so we have reduced the duration and also the dose. After these randomized controlled trials, we have published last year in Pediatric Nephrology the international guidelines for nephrotic syndrome management of the International Pediatric Nephrology Association. You can go to the website, ep10.org or something like that. And if you go to guidelines, it's free. You can download the guidelines in English or translated into 14 languages. We have also produced documents for the patients with cartoons that you can give to your patient to explain the disease and the treatment, and everything is free of charge. There are also slide sets for teaching that you can download on the Ep10 website. So what do these guidelines say? Well, these guidelines say that the treatment for nephrotic syndrome should be prednisone or prednisolone, 60 milligrams per meter square per day for 4 weeks, to a maximum of 60 milligrams even in larger and obese children, and then 40 milligrams per meter square every other day during 4 weeks. That's for the first flare. Then, if there are subsequent relapses, we have also shortened the dose. So you go back to 60 milligrams per meter square per day until 3 days of negative dipsticks. And then 40 milligrams per meter square every other day for 2 to 4 weeks only, and then you stop. And there is no need to do some progressing tapering. Yeah, because it was shown that it doesn't change the outcome. So you see that it's greatly reduced. Now, if you have 2 relapses in 6 months, or 3 relapses in 12 months, or if you have steroid-dependent relapses, meaning while the child is already receiving steroids, or if you have complicated relapses with acute kidney injury, hospitalization, big infection, then you have to add a steroid-sparing agents. So we don't have good data to choose which one of them. So usually in Europe, and that was what we discussed during a ground round yesterday, is that we would favor, if available in every country, we would favor the less toxic and then go to the more toxic. So first, we would use levamisole if possible, because that's not an immunosuppressive drug, that's an immunomodulatory drug. So you can try levamisole, but if levamisole is not working, then we recommend to go to MMF, mycophenolate mofetil, because it has only transient side effects. So if there is side effect like abdominal pain diarrhea or leukopenia, and you reduce the doses or you stop, they are completely transient. And if the child continues to have relapses on MMF, then we recommend either cyclosporine and tacrolimus or rituximab. So cyclosporine and tacrolimus are more efficient than MMF, but the problem is the nephrotoxicity. So we recommend to try not to use it for more than 2 to 3 years if possible. Rituximab is very, very efficient. The problem is that when you use repeated doses, you may have hypogammaglobulinemia and sometimes severe infections, and even there were some rare but reported deaths. So what was shown is that to use rituximab, it's safer to wait until the child's immune system has been completely formed, so around 7 years of age, but that's not, that's not definitive. Yeah, so probably if MMF doesn't work, the European expert would go to CNIs before 7 years of age, or to rituximab after 7 years of age.
And if we have like a remission, child is okay, if do you recommend MMF to taper first and then to stop?
So what we recommend is that if the child is in a stable remission with no relapse for a year, to try to stop the treatment. Then nobody knows if you can stop it right away or if you have to do a progressive taper. Yeah, that's, you know, I think that's doctor's preference.
Yes, yes. And it was mentioned also the possibility of determining the target therapy to do flow cytometry. Would it be possible now for our children?
Well, Manuela Colucci from Italy, she published very interesting data showing that in children at first diagnosis of nephrotic syndrome, all the B cell subpopulations, total B cells, memory B cells, atypical memory B cells, switch memory B cells, and antibody-producing cells are increased, and Tregs, a part of T lymphocyte that prevents autoimmunity, are reduced. And so from her FACS analysis, when she looks at the unswitched memory B cells, if the level is above a certain cutoff, 1.5% of the total number of B cells, then the risk of subsequent relapses is very, very high. So from that, maybe in the next future, we will change our practice in those children and maybe introduce a steroid-sparing agent since the diagnosis.
Like the first line treatment.
Like, for instance, levamisole. In the working group for nephrotic syndrome, we had an update on 3 randomized controlled trials that are done in Europe, in France, Netherlands, and Germany. And in Germany, they start MMF since the diagnosis. And in France and the Netherlands, they start levamisole since the diagnosis. And from the French randomized control trial, we can see that it greatly reduces the number of relapses afterwards, even after levamisole have been stopped.
Okay, so there is a hope for these children.
So there is a hope.
Yeah, and it's working, even in pediatric generation, because in adults there are studies more, but in pediatrics, so we are very happy about it, about our children. Thank you very much, Professor.
My pleasure.